Hello, my name is Jacob Capin, and I will be presenting on reduced variation following a care guideline implementation, analysis of 11,063 patients after total knee arthroplasty. Note that our sample size changed slightly on our final analysis. Unwarranted variations in clinical practice are differences in care that cannot be explained by the patient's condition, the available evidence, or the patient's preferences. There has been a recent call to move beyond describing unwarranted variation and identifying strategies to improve care and reduce unwarranted variation in clinical practice. Unwarranted variations occur widely across clinical settings, including orthopedic conditions such as total knee arthroplasty. Total knee arthroplasty, or TKA, is one of the most common and costly orthopedic procedures, with 1.26 million TKAs projected by the year 2030 in the United States alone. TKA is an outstanding model for investigating variation in outcomes for several reasons, including its high prevalence, as well as the fact that it's a relatively straightforward orthopedic procedure with a relatively common set of complaints and rehabilitation goals. Prior research has investigated variation in outcomes for total knee arthroplasty. However, this prior literature has emphasized the immediate post-surgical outcomes, including length of stay, cost, and place of discharge. There are regional disparities in post-acute rehabilitation. There's also a six-fold variation in cost between the 90th and 10th percentiles of total cost across the United States. Insurance status may be a major determinant of care. Prior research, however, has not evaluated variation in outcomes of outpatient physical therapy for total knee arthroplasty. Prior literature has, however, examined the content and delivery of rehabilitation for total knee arthroplasty in both the inpatient and outpatient settings. We know that there is considerable variation in the timing, use, and exercise content of physical therapy following total knee arthroplasty, including suboptimal exercise for strengthening. Evidence-based interventions may be underutilized and dose may be insufficient to obtain optimal outcomes. We also know that modalities without proven benefit are overused, accounting for about 25% of the time and costs of care. Early initiation of inpatient and outpatient rehabilitation are associated with better outcomes. In summary, we know that there are large studies of perioperative outcomes or small studies examining content and delivery of outpatient physical therapy. However, it is unknown whether and to the degree of which variation occurs in outcomes for outpatient physical therapy. It is also unknown the impact of addressing unwarranted variation on outcomes. The purpose of this study was to describe the variation in outcomes and visit utilization before and after implementing a care process guideline, or CG, for outpatient total knee arthroplasty rehabilitation. We had three hypotheses. First, that the Knee Outcome Survey, or KOS, change scores would be greater while visit utilization would not differ meaningfully in the care guideline versus non-care guideline groups. Second, that variation in the KOS change scores would decrease modestly within clinics and substantially between clinics after implementing the care guideline. And third, the variation in visit utilization would not change substantially after implementing the care guideline. This study employed a retrospective analysis of the Rehabilitation Outcomes Measurement System, or ROMS system within Intermountain Healthcare System, a large healthcare system based in Utah. There was a presentation immediately prior to mine by Stephen Hunter and colleagues that provides significantly more details about this system and the process and introduction and adoption of the care guideline. So I will only cover it very briefly here. We included 11,063 patients following primary total knee arthroplasty, with 2,288 patients in the 5 years of 2008 through 2012 when care was not standardized, and 8,775 patients from 2014 to 2019 who received care according to the care guideline. We excluded patients with a prior TKA, fewer than 5 visits, age less than 18, and the year 2013 when the care guideline was introduced. Again, details of the care process guideline are found in Hunter et al.'s presentation immediately prior. However, I'll provide a few elements here. The Care Process Guideline was a 3-day hands-on course for physical therapists for its first introduction in the year 2013. There were a number of basic care guidelines that were emphasized, including exercising each week, measuring range of motion each week, and not using sensory electrical stimulation or TENS beyond 2 weeks due to lack of evidence. There were both process and outcome goals with benchmarks, and physical therapists had on-demand customized access to patient outcomes. Feedback was provided through chart audits and peer discussion, augmented by incentivized annual goals. See Hunter et al. For more details. Our primary outcome measure was the Knee Outcome Survey Activities of Daily Living Scale, or KOS. The KOS is a patient-reported outcome measure that captures knee symptoms and functional limitations during activities of daily living, such as walking, rising from a chair, and climbing stairs. The KOS is reliable, valid, and responsive. For our statistical analyses for Hypothesis 1, we used a Bayesian hierarchical linear regression model using the KOS change score, which is the final visit minus the baseline visit scores, as the response variable. We included several fixed predictor variables, including patient age, date of injury surgery, number of visits, baseline KOS score, patient sex, patient BMI, baseline pain score, area deprivation index, and if the payer was Medicare. For Hypothesis 2, we looked at the ratio of the standard deviations of the KOS change scores of patients within each clinic in the care guideline versus non-care guideline groups, and between clinics in the care guideline versus non-care guideline groups. For Hypothesis 3, we use the same analysis as for Hypothesis 2, but using visit utilization as the outcome. Our results for Hypothesis 1 were supported that KOS scores were higher in the care guideline group versus the non-care guideline group. Here we have the mean KOS change score, so the change from baseline to final visit in the non-care guideline group on the top and the care guideline group on the bottom. As you can tell from the graph, there are better outcomes in the care guideline group, which averaged approximately 30 points of change, whereas the non-care guideline group averaged approximately 24 points of change. Moving now to looking at clinics individually, the second part of Hypothesis 1, on the y-axis we now have each individual clinic, and on the x-axis we have their change in change scores. In other words, the difference between the care guideline group minus the non-care guideline group. The yellow line indicates 0 or no change, and any value to the right of the yellow line indicates an improvement in outcomes after the introduction of the care guideline. As you can see by the black dots, which represent the mean KOS change scores from before to after the care guideline introduction, every single clinic improved. However, only 8 of these were statistically significant, and 3 exceeded the MCID of 10 points. Moving now to visit utilization, we have the same schematic as in the prior slide, except that visit utilization is now the outcome variable. You can see that there's no pattern in visit utilization from before to after implementing the care process guideline, with scores mostly hovering around 0. In other words, indicating no change. Visit utilization after implementing the care guideline did not change significantly or meaningfully. Moving on to results for Hypothesis 2, we found that the KOS change score within clinic variation decreased 6%, while between clinic variation decreased 60%, as shown in the figure here. Decreasing variation or values less than 1 indicate improvement or a decrease in variation. Moving to Hypothesis 3, this is looking at visit utilization and the change in variation of visit utilization, both within clinics and between clinics. Again, values less than 1 indicate decreasing variation, which is considered an improvement in care. Visit utilization within clinics decreased 6%, the variation of visit utilization decreased 6%, while between clinic variation decreased 39%. However, this was not statistically significant due to a large confidence interval. In summary, KOS change scores improved across all 49 clinics without a change in visit utilization. Variation in KOS change score decreased 6% within clinics and 60% between clinics after implementing a care guideline for TKA rehabilitation. Variation in visit utilization decreased 6% within clinics and 39% between clinics after implementing a care guideline for TKA rehabilitation. Our findings suggest a care guideline may improve outcomes across PT clinics, especially those performing initially at lower levels. Dissemination of a care guideline may be effective within a large healthcare system, which is applicable to the growing number of multi-site physical therapy practices across our country. There are limitations to consider. First, changes may have occurred due to time or monitoring alone rather than due to the care guideline itself. However, there were no observed trends in improved outcomes during the 5 years before implementing the care guideline, as shown in Hunter et al.'s presentation. Second, neither clinics nor facilities were randomized to receive versus not receive the care guideline. However, we included several fixed predictor variables, none of which differ between the NCG and care guideline groups. We had a very large sample size, and it was a pragmatic design. Third, function was evaluated using a patient-reported outcome measure rather than a performance-based functional test. However, the KOS is reliable, valid, responsive, and condition-specific. In summary, implementing a care guideline improves outcomes while reducing unwarranted variation in TKA outcomes across PT clinics, likely reflecting broad adoption of the care guideline by providers. I'd like to thank the funding sources, especially those that have supported my postdoctoral fellowship, the Academy of Orthopedic Physical Therapy, the Department of Veterans Affairs, and the National Institute on Aging. Thank you.